Hi guys, a very good evening to everybody. So on this pre-Diwali week, we here we are. I mean, time just flies, in fact, and here we are, just ready to discuss some MCQs which have been asked in the recently concluded exam. So let's just focus on a couple of issues for today. The audio and the visual part looks pretty decent to me at the moment, and here we are good to go. Hi Ayush, good to see you here. I'll be using a couple of inputs that you helped me with. Hi Lakesh, Dr. Divya, Dr. Shahrukh, Harsh, Medical Love, then Dr. Ulla. So I missed a couple of names, but very good evening to everybody. Hi Mukesh, good to see you. So here we are. I had a mixed response with respect to the type of paper that was asked. I would say a moderate paper, but yeah, obviously tricky options. So let's just focus on the aspects that we're going to discuss today. The disclaimer is anyway mandatory to be said. This is a recall based session. So very good evening, Dr. Mahima, Dr. Ashwani, and Dr. Harsha. And I think we're good to go. Starting with the very first question for today, I'll just zoom it in slightly for your convenience. This talked about a 14-year-old boy brought his who by his father, who has noticed him that he's having agonal respiration, and that's at 5 a.m. in the morning. So that's a very characteristic manifestation of this condition that we're going to discuss in a while. And the patient was rushed to the emergency room where the ECG is showing the co-pattern of ST segment elevation. I think the key word in this MCQ is the co-pattern of ST segment elevation. And I have highlighted this multiple times. In fact, you can see that this would be having a very characteristic T-wave inversion, and the ST elevation that is seen in this condition would be grossly different from the one that we see in myocardial infarction. Oh, thank you, boy. So we have is a co-pattern in lead number V2 and V3. That's mainly because the defect in this condition would mainly be present with respect to the right ventricular epicardium, and therefore since the co-pattern is present, and I have said multiple times, the leading cause of sudden nocturnal death in a Southeast Asian male, it should always be answered up as Brugada syndrome, and the key word is nocturnal. So this was an early morning episode and the patient has died, and the patient would be requiring a pacemaker. Why answer is not option number A? Because this would be physiological and this will not cause any harm to the patient. Option number C can be easily ruled out, primarily because hypertrophic cardiomyopathy will mainly be related to physical activity, maybe like playing football or any sports related activity, and anyway the ECG of atrial fibrillation does not show any ST segment elevation. So we are spot on for this one. In case anybody wants to modify the presentation, you're most welcome. Otherwise, I think we are sorted for the very first question for today, which was Brugada syndrome, and was an easy pick. And I'm really happy that a lot of guys were able to pick this up. And in case you have not, then I've said the keywords: ST elevation in V2, V3. The co-pattern is the keyword that I've hand drawn. Suggested read is, in fact, these two videos from cardiovascular system is always to be read for any exam. Cardiomyopathy is one, and second is TACUA, and TTCM and Brugada syndrome. So traditionally they've been asking about broken heart syndrome in the previous years. Now they have started asking about Brugada. It's a SCN5A defect. It's a sodium channel defect, and you would be requiring implantable cardioverter defibrillator for this condition. Absolutely, Himanshu, you're spot on for the treatment for this condition. So we are sorted for this one. Good evening to everybody. We go to the second question, in which there were a couple of missed beats present. I'll just put a vertical arrow for the missed beats, because you can pick up a T followed by a P, but then there is a missed beat present. And what's happening is that every time the patient is having a missed beat present, this is gonna be a presentation of a heart block, and your objective would be, wherever the missed beat is present, just check out the PR interval after and check out the PR interval prior to it. And this looks almost symmetrical, so that tells you that this would be a Mobitz 2 heart block, and this again is a repeat. I think the ECG may not be identical, but what you can pick up in this particular condition is, and my suggestion to you for the forthcoming exams in the NEET exam would be that don't waste your time trying to check out the PR interval again and again and again, because that causes undue stress and undue pressure on the mind. So what is always recommended is yeah, I mean that's by God's grace, that's the thankful thing that they've done, that this is a second degree heart block. But still, just as a teacher, my job would be to tell you that in Mobits 1 versus Mobits 2, I mean, don't waste your time counting that PR interval multiple times. That can cause mental fatigue. So just check out the PR interval before and after, and as you can see in this case, this is gonna be symmetrical. What I mean by symmetrical is the value of PR interval after and before is equal, so that makes it Mobits 2 heart block. So we are sorted for the very first two questions for today. For those who have joined in, the first question that we've discussed is the leading cause of sudden nocturnal death in Southeast Asian males. That's Burgada. And then we have just talked currently about second degree heart block. So we are sorted for this. Okay, Mukesh, you did a good attempt, but then this would not be a third degree heart block. So good. Let's move on to the next one, the third one for today. Keep the choices coming in, guys. If you find any modifications with respect to the age group, the presentation, most welcome to let me, I mean, you are most welcome to interject at this particular point of time. So, yep, Sagar, that would be Mobits 2 heart block. We have this 60-year-old diabetic male with central chest pain, shortness of breath, and palpitations, and the ECG shows a non-ST elevation MI. And you're aware that non-ST elevation MI will always be a platelet-rich thrombus, and because it's a platelet-rich thrombus, therefore I have to use dual antiplatelet therapy, and I'm not going to do thrombolysis in this particular case. So aspirin would be in, clopidogrel would be in, and apart from this, I also need to use the anti-clotting drug, that would be enoxaparin. And yes, Dr. Paul. I mean, just keep focusing on the concepts, and you'll be most. Statins was present. Okay, Nilofer here comes up with a good input. Nilofer, in which option? I think it was with aspirin with VK. So I think I just picked it up very nicely. It was aspirin with statin, but I presume that as far as option C is concerned, that would be the main treatment that we would be giving, because statin is going to be very, very good for, I would say, preventing further progression of atherosclerotic heart disease. Yes, we would be giving. There were ST elevation. Okay, Dheeraj also says that there was a ST elevation in 2-3 AVF. Okay, cool. That would not change the real perspective, because inferior wall MI anyway, we don't use nitrates and we don't use beta blockers. But then the remaining things would not really matter. So cool. I think for that was a very good input that you provided, and we are sorted for this one. The answer for this one. Okay, Dheeraj. Very okay. Dheeraj, can you just comment on what did this question have a ECG? Okay. Yeah, Roshan. Still, even if you don't say acute management, if ECG is showing ST elevation, you have to go for acute management. Okay, so ECG was present. Okay, Dheeraj, so what I'll do is I'll add up a ST depression for this particular case. There would be ST depression in lead number 2, 3 and AVF, and I think along with that there would be a T-wave inversion as well, because he's mentioning, I think everybody is clear with respect to the fact that why are we using antiplatelet drugs for this patient, because it would be a platelet-rich thrombus and we need to use anti-clotting drugs in this patient. Yeah, Dr. Malu, I have this question here before you. I have it towards the end, so please be patient, Dr. Malu, and I'll discuss that MCQ. And good that you have come up with that particular question with respect to visual agnosia. I'll just describe it, anosognosia versus visual agnosia. I'll be explaining this. The question is very much on the radar, and Dr. Maloof, just for your satisfaction, what I'm gonna do is I'm gonna just focus on that question, and since you mentioned a couple of choices, so I'm just gonna take a snapshot of the same as well. But anyway, the question is gonna be discussed, so please be patient for the same. We are sorted for this question. This showed an ECG that was showing probably a T-wave inversion with a ST elevation, and no, I don't think so. This would be of any benefit to a FMG student, because if you've not given an exam, you'll not understand the gravity of the situation. So let's keep it INI-CET oriented only. Knowledge is always welcome. If you can figure it out, great. So anyway, we are sorted for this one, and let's move on to the next one. Very interesting question, and I think this has again not been discussed. Patient was being treated in intensive care unit for sepsis. The ABG of the patient shows a pH of 6.9, a PO2 of 80. I have another slide where I have focused on the differences in the two ABG reports that were given in this patient. I give you few seconds to just have a look at the permutation combinations of the options and let me know if these are okay. I mean, the options were, what I have figured out is excess heparin, excess air, and then less heparin, less air, and the permutation combination of the same. So waiting for input from you guys with respect to the accuracy. Don't worry about the values, that I'll explain to you the modifications, but just let me know if the options are right, because that would make more credibility. Okay. Okay, only air, then says heparin and air and only heparin. Okay, excess air was only one option. Okay, okay, fine. Okay, fine. Anyway, doc, I'll be able to give you justification for each one of the presentations in this particular case. PO2 was 148. For the Kaushal, can you mention for the PO2 for 148, was it for the first ABG or for the second ABG? I got it. I'll just explain to you. Fine. So there were no permutation combinations with respect to 2. It was excess air versus excess heparin. So I'll just do justification, and here it is for the options. Now focus on the image on the slide before you. I think one of the images or one of the options in this particular case was with respect to PO2 of 140. Okay, Mohan Raj mentions regarding a PO2 140 in the second one. And can you comment on the one in the very first one? Can you comment with respect to the PO2 in the very first one, the first ABG report, in case you can? Otherwise, I'll just sort out the question for you. The question can be sorted on the pH report of the patient itself and the value of the bicarbonate. Okay, fine. So I think we are good to go as far as the image is concerned, guys. My point is, in this image, there were two, in this question, there were two ABGs that were given. The bicarb of the patient was stating to be almost constant. That means that probably even if you are given a soda bicarbonate correction, there should be an improvement in the pH of the patient. Like the pH of the patient initially is 6.9 and then is turning out to be 7.1. So if there's an improvement in the pH of a patient, I anticipate, okay, Nilofer, doesn't matter whether it's 80 or 90. My point is simple, that if there is an improvement in the ABG of the patient with respect to the pH, now focusing on the pH component of the movement, then I'll say that this particular patient would be having improvement because of the excess of, because of the correction of soda bicarbonate, the pH should be improving. But if the pH is improving even without the change in the bicarbonate value, the first plausible explanation would be excess heparin in the patient. Okay, so Mukesh is giving up our input. Let me just explain. The basic concept behind this MCQ is, and I'll just show a slide for the same, which will make it relatively easier for you to understand, that if you take too much of heparin, what it basically contributes is a change in the pH values. And in fact, if the patient's original pH values are excessively low, it can result in a falsely elevation of pH. It can cause the pH values to be slightly elevated. So one of the more plausible explanations for that, if the bicarbonate value is not increasing, that means that soda bicarbonate correction is not responsible for that change in the pH, because traditionally the pH from 6.9 to 7.1 should be rising primarily with respect to the possibility of a soda bicarbonate correction. If that is not happening, that would be excess of heparin present in a sample. So one thing is very clear, that the heparin component will be satisfying the improvement in the pH in this particular case. And the second aspect is the heparin, if it is too much, can actually contribute to a dilution effect. The dilution effect can contribute to changes in the value of PCO2 and the PO2 values as well. So if I focus on the ABG report, there can be some differences in the recall values. Don't bother about them. In my opinion, the way the things should be, logically the things should be that one of the ABG should be having a relatively higher PO2 and the second one should be having relatively a lesser value of a PO2. I think this will make more sense, because then heparin will be causing a dilution, and because of the dilution, if you look at the two ABG reports, I can say that heparin excess can explain the current permutation combination that is present, because one, it is showing an improvement in the pH, that's the effect of heparin, and second is the dilutional effect which is caused by it. So excess heparin would be the best way to describe the manifestations in this particular case. So hi Dr. Guliani, good to see you here. And anyway, the options for this would be modified, but the reason or the logic for this would be excess heparin and not excess of air, because if it was excess of air, then the pH values would not have changed. I repeat that again. If you say only excess air, then that does not explain the change in the pH values, change in the pH value. So has to be heparin which is contributing to it. So I think I got a fair bit of idea with respect to the values and the permutation combinations and the dilutional effect what heparin would be causing. And from the options here, well, the best one from the current options that I've given, it would be excess of air and excess of heparin. But since you said that there were two separate options and there was no combination possible, so in my opinion, the best way for this would be, yeah, excess air will be causing Mohanraj. But that's why I modified the situation, right? So if you look at this image, I said that probably the change in the PO2 of the patient would be reversed. Like the 140 value would be for a different ABG report of a patient. So I'll just justify this once again. If you have a combination of excess of air as well as excess of heparin, then the combination, Dr. Mohanraj, what you said. Yes, Dr. Chakrabarti, that is what I'm trying to say. I'll have to reverse the values for the same. If I change this 80 to left and 140, then the combination of excess air and excess heparin will definitely be working. But in case you are saying that they are separate options, then it really does not work. So I think the way things are, the concept to be remembered is that is probably the source from where they have generated this particular question with respect to the variations in the pH and the variations in the PO2 and the PCO2 of the patient. So anyway, when I come back to you, we'll give a much more refined version of this multiple choice question, considering that we are trying to assimilate and collect the options in this particular case. So good. Mukesh is coming up with another option, so I'll not get into that. Let's just focus at the job at hand. And anyway, this I think has not been discussed anywhere else, so I thought I'll just put it up on the discussion at the moment. Let's focus on the next question, which is leading cause of hypercalcemia in a hospitalized patients. As far as parathyroid adenoma and parathyroid hyperplasia is concerned, patients are mainly gonna be asymptomatic. This would can be ruled out easily, primarily because the remaining ones or the remaining two would be causing this. Option number D I can rule out because it is iatrogenic, and option number B and C I can rule out because most patients are asymptomatic. The correct one for the current option would be malignancy, and that would be mainly a squamous cell cancer of the lung, and lung cancer will cause so many manifestations that patient will anyway suffer. So answer to this one is option number A, and at this point what I'll also do is just type in my email ID, Dr. Nilofer and a couple of other doctors who did mention regarding the options for the previous one, the ABG one. Do let me know the exact values for PO2 and PCO2 in case you do remember them. I've just put down my email ID for the same. So I think we are sorted for this one, and the subsequent question on the focus would be one for infective endocarditis. The options which were given for this case were very weird. In fact, one of the options was like when one of my students told me, I was like, really? I mean, did they put up that option that you were taking a sample from the affected heart valve? I mean, very shocking statement for a diagnosis of infective endocarditis, that you're taking a sample and that too from the affected heart valve. Guys, I think we have discussed multiple times that for diagnosis of infective endocarditis, you need to take at least 3 samples, and these samples should be taken at least 1 to 2 hours apart. So it should be a total of 3 sets from peripheral sites. And somebody commented about C also. So doc, will not be either putting a central catheter, and to take a sample from a central vein would not be very much advisable. It's from peripheral veins because we wanna prove that there is a dissemination of infection. So taking it from a central vein, because you see central vein will be sending blood towards the heart. I mean, my point against point number C is the central vein will take the blood towards the heart, and in infective endocarditis the vegetations are going out of the heart. So if we have to take a sample, it should be from a downstream circulation rather than upstream circulation. By upstream I mean that if blood is going towards the heart versus blood that is coming out of the heart, blood going into the heart would not be having vegetations, blood coming out of the heart would be having a presentation. So option 1, central line, which is already present in the patient. Okay, Dr. Monraj, again that the concept that I described, no, that even if a central line is present in a patient, central line would be present sending blood towards the heart, whereas vegetations are coming out of the heart and would be getting distributed in the distal circulation. So yeah, Mohanraj, that's what I'm trying to say. For the third option, no, that would be 2 sample periphery and 1 sample from already placed. I'll make out of that from 1 central vein. That's okay. I mean, there's a central line placed, But then considering 30 minutes apart, that again goes against it. So I would put my best money on option number D for this one, where there would be 3 sets of peripheral sites and that would be 1 hour apart. That would be the best bet to diagnose infective endocarditis. The point against option number C, I know that you guys are vocal with respect to the options, but then as far as C is concerned, 30 minutes apart and then the center line concept is usually not given. At least the textbook doesn't say like that. It just says 3 samples should be obtained from different venipuncture sites, and he's mentioning the word venipuncture also. Right. So if the textbook is mentioning venipuncture, then already placed central sign would not be a very big option. In fact, I mean that would not be a correct option to select for from the exam perspective. The 2 keywords which I'm showing from the textbook references venipuncture, that's one point that straight away goes against taking a sample from a central line. So hi Ranveer, and okay, Pooja, can you let me know then the option which is present? It's if it is 3 sets from peripheral sites, or even if you say 3 sets and it can be 2 from central and 1 from a peripheral, but then the distance or the difference between them has to be 1 hour, no? It can't be 30 minutes apart. So if you say that C versus D, Dr. Monraj, infective endocarditis will mainly be affecting the left side of the heart, no? So the blood is going, the vegetations are not flowing into the heart, right? The vegetations are going out of the heart. Okay, option number D was catheter tip. Great. D was catheter tip. Okay, Ishan, I got it. Then I got your point, doc. If it is gonna be a catheter tip, then we're not gonna take it from a catheter tip. Then the way the question is given at the moment, I'll say like this. If it is 3 sets of samples from peripheral sites 1 hour apart, then that's the best bet. That's how we traditionally go about it. In case it mentions catheter tip, then the best way to, I mean, central catheter tip is, I mean, taking out the central catheter would be one of a very good options that we can go ahead again, considering that 1 hour is mentioned. See, the point is catheter tip can be infected, no, so we can set it for the culture again, because that center line could have contributed to development of infective endocarditis. That could be one of the plausible explanation that I can say, but I'll still focus on that 1 hour duration, and along with that I'll be removing that center line and I'll send the catheter tip for a culture to prove that that is the source of entry of infection into the body of the patient. So Ishan, I got your point. I think we'll still go by D, but then catheter tip comes in, and that sending that catheter tip for culture also makes sense. Great. So we sorted for this one for the options. We'll come up with the refined versions of this in the app. And this I think is much more a easier one. They have talked about anti-diabetic drugs which are used in heart failure with low ejection fraction and reduced urinary output multiple times. The concept is SGLT2 inhibitors are mainly going to be cardioprotective, and they're going to reduce the CV mortality. The updated diabetes guidelines also talk about it. So that is why empagliflozin would be the best bet and the correct answer for this one. And as far as the remaining ones are concerned, well, they do not, pioglitazone per se will be worsening cardiovascular mortality. So SGLT2 inhibitors are the best one that can be used for management of these patients. And similarly, even in a scenario for reduced urinary output, I can say that SGLT2 inhibitors can be used even if in the patient the EGFR is less than 30. Even if the EGFR is less than 30, even then we can be using SGLT2 inhibitors. So this would be, the UTI is a side effect, that's okay, but at the same time they have been shown to be beneficial. Mohan Raj, creatinine mentioned anyways. Mohan Raj, could you comment on the one that you just mentioned, creatinine of 9 milligram mentioned? Okay, got it. In this question with urinary output, the KFT of the patient was deranged and the serum creat of the patient was elevated. Okay. So he is elevated. I mean, the guy is not going in for a dialysis at the moment. It would be mainly SGLT2 inhibitors that would be beneficial at this particular point of time. Okay, then he says, which of the following is not a component of metabolic syndrome? I think I got 2 versions of this MCQ. In one, I think some guys were saying it was hip circumference, and a couple of guys were saying no, it was waist circumference, which are high LDL. The correct answer for this one, okay, option number C was hip circumference. Fine, doc, then it is not an inchu. If it is hip circumference, then that would be the answer to this MCQ, and we'll have to remove the word high HDL from the discussion, because then it would only be with respect to HDL values. I mean, it is not high HDL is gonna be cardioprotective. No? So fine, got it, Mohanraj. Hip circumference mentioned. Then the best answer for this one, the correct answer for this one is option number C. That is with respect to the word hip circumference. And version 2 of this was that HDL of the patient is elevated versus the waist circumference, then elevated HDL would become. Gauri, high HDL is gonna be good for the heart. No, it's not a component of metabolic. It would be a lesser value. It would be a lesser value. There are two aspects. I'll just say once again. One is if you are having abdominal circumference in the MCQ, then it should be a component of low HDL in a patient. Okay. Okay, Nilofer, in case you can find a better version of whatever you commented in the chat part there, it would be great if you can just mail me that, and I'll be in a better position to understand it, because that looks like isolated statement to me at the moment. The main concept is abdominal circumference and low HDL is the component of metabolic syndrome. The total of 5 manifestations which are present, and the key word for the question would be mainly that we have to pick up abdominal circumference versus hip circumference. Otherwise, it's gonna be elevated HDL as an answer. So fine, we are sorted for the same as well, the two versions of the questions that I had. This I think the pathologist has discussed, but I'll just take my point there. Only one option with 3 sides and the rest was 3. Yeah, Amit, that is what we are trying to focus on. No, the 3 sides have to be given the importance, and I think Amit, it is like 2 sides with 1 extra central catheter that was mentioned. Okay, coming to the one currently on focus, this is about a 75-year-old woman, diabetic hypertension, and then you can see that pink amyloid material between the myocytes, so that goes in favor of a restrictive variety. On the other hand, I've also shown the characteristic myocardial disarray. That myocardial disarray would be for, if it came, maybe in a set, then that would be hypertrophic cardiomyopathy. That would also be having fragmented nuclei present. And in case we are having that Titan star appearance, the Titan star would be responsible for dilated cardiomyopathy. So that's the take-home message. Depending on the kind of slide that is coming up, the ninja star appearance is the one on the extreme right-hand side, and that would be for DCM. The correct answer from the more probable, or the one that was slide that was mentioned, was the amyloid protein deposition for restrictive cardiomyopathy. When it is contraindicated in a Nilofer, we can be using SGLT2 inhibitor only. I mean, your question is, when is SGLT2 inhibitor contraindicated? Only when patient is scheduled for dialysis. Otherwise, even if SGLT2, even if a CKD patient is having a eGFR of less than 30, because 30 is usually the time when we'll plan either a transplantation or a dialysis in a patient, but even if the eGFR of the patient is up to going to less than 30, even then SGLT2 inhibitors can be using. Restrictive cardiomyopathy can, see doc, none of them will be causing hypertension. None of them would be causing hypertension. Hypertension is rather more common in old age group. Hypertension is the relation between hypertension is mainly the age of the patient, and that has nothing to do with the manifestation. In fact, hypertension would have contributed to death of a patient. None of the cardiomyopathies would result in development of hypertension. So even if you say that, okay, hypertension will cause, RCM will cause, none of the remaining one would also cause hypertension. For hypertrophic cardiomyopathy, age would be a difference. I mean, usually the age of presentation of hypertrophic would be between 20 to 40 years of age. That's the usual profile. Takotsubo cardiomyopathy is anyway gonna be acute onset or sudden onset. So this is gonna be unlikely as a presentation. So we are left between 2 only. Yes, that is what I'm trying to say more. 75 years of age, hypertrophic cardiomyopathy is unlikely, sir. He would have suffered so much in his life, and then the manifestations would have been of heart failure, chest pain described, which I think was not given. So I think majority of people and majority of images that I got, they were in favor of amyloid protein deposition. But anyway, for the sake of discussion, I mentioned the myocardial disarray and the fragmented nuclei as well, based on the age group and the histopathological image. The diagnosis in this patient is mentioned. Doc, it always has been the same way. Every time we feel like this, that we have not read enough, and then our subconscious memory kicks in, and that helps us get a couple of questions correct as well. Okay, we focus on a 40-year-old lady. She's having a bilaterally symmetrical tender involvement of the hand, early morning stiffness. So osteoarthritis will be involving the knee joints, and the age of the patient would usually be, I mean, most of the time osteoarthritis would be involving patients between 50 to 60 years of age. Psoriatic arthritis will be having a DIP involvement, so can be involved, and then gout would be having first MTP involvement. So we are left with rheumatoid arthritis only, and that's a pretty straightforward one. The answer for this one would be option number D. I think this was one of the easier ones, so no confusions on this one. Fine. Coming to the subsequent one, he says a 26-year-old lady, she's presented with palpitations, weight loss, tremor, sweating, and diarrhea. Considering that there is features of sympathomimetic stimulation and weight loss also given in this question, especially in a female patient, we'll have to think in terms of a deranged thyroid function test in these patients. And okay. Considering that we are having presence of sympathomimetic stimulation with weight loss, we'll think in terms of thyroid derangement in this patient, and then I'm getting options like only TSH option is there, so there is no free T4 in the patient. Okay. Okay, so we are not gonna have, this is only TSH, only thyroid stimulating hormone. See, TPO antibody will mainly be for Hashimoto's, so that can be ruled out. We are left between A versus B. So I'll just show the protocol from Harrison, and then it will make it relatively easier for you to comprehend. That he says that what is the next test that will help in establishing the diagnosis in this patient. So TSH, total T3. Okay, so there was no T4 present. Okay, ultrasound neck, and TPO antibody. Okay, fine. So guys, the correct answer for this one would be thyroid stimulating hormone. I'll show you the Harrison reference for the same. In the evaluation of hyperthyroidism, what is mentioned is that yeah doctor, I get your point, Dheeraj. He says you have to measure TSH, and why he's not mentioning T3 is because what is produced by the gland is not T3 now. What is mainly produced by the gland is T4. So in any patient with evaluation for hyperthyroidism, the initial test to be done in a patient would be a TSH value and then a T4, because subsequently it would let you know also that absolutely, Amit, that's perfectly spot on, because TSH would let you know whether you are dealing with a primary cause, whether you're dealing with a secondary cause, because you anyway need to make a differentiation and then go into the cause as well. And T3 values are alone not useful for diagnosis, because what is produced by the gland is not T3, what is produced by the gland is T4. So I think it was a very well designed question with the two options between TSH and total T3. We check free T3 and T4. Exactly, Achnana, that is the point. We always check free values of free T3 and T4, and they are the ones that are useful for diagnosis. It is not a total T3 value, that would not be useful. So I think we are sorted for this one. The correct answer for this MCQ is option number A, and TSH is overall the best function test. I've given the Harrison snapshot and the reference for the same as well to prove that Y is the answer, thyroid stimulating hormone. Moving to the next question, he has mentioned regarding, okay, he said diagnosis of hyperthyroid. He himself mentioned thyrotoxicosis. Next time to confirm your diagnosis. So yeah, doc, that's the algorithm given in the textbook to evaluate any patient who's having hyperthyroidism. So after TSH, we'll be doing free T4 values. It is free T4 values. Again, you see, specific test is, again, it's not about specificity, sir. It is about the algorithm which is right on the textbook before you. We can't change it according to ourselves, right? I just can't say that, okay, free T3, free T4 kara lo. RD to we'll go for a total thyroid function test in a patient only. But then if we follow the textbook protocol, T3 is much more lower down, no? Only in limited cases are we evaluating for T3. So if we say that what is the specific test that would help us in evaluation of this chap, we'll have to do a TSH and a free T4 values. The concept is what I said, that what is produced by the gland is the T4 values. Okay, so the next one, I do have references for describing the answer for this question. He mentions recurrent episodes of abdominal pain with only 3 to 4 episodes present. So that makes the patient as suffering from mild ulcerative colitis. And for patients of mild ulcerative colitis, it is sulfasalazine that yes, it is a case of hyperthyroidism. Clinical history is suggestive of hyperthyroidism only. Na? That is, even if that word hyperthyroidism is, I have not written. I mean, all these manifestations are said. Sympathomimetic stimulation and weight loss implies that what you are thinking in this particular case is hyperthyroidism. And then he says, what is the step for evaluation of this patient? So the step for evaluation of the workup of the patient is what I have described. Okay, coming to the manifestations, there is a mild ulcerative colitis from which we'll be using sulfasalazine. The remaining options can be ruled out. Only for a person who's having exacerbations that we'll be using budesonide. Anyway, this small step up table would help you analyze the step up therapy that we'll be using for mild to moderate ulcerative colitis. So for which one, doc? Dr. Kalita, can you just quickly comment on which investigation choice are you asking for? We are sorted for this one. I'm moving ahead, and the question mentioned regarding hepatitis B profile of a patient where the protection antibody was negative. I think surface antigen was also negative. HBsAg was also negative. Protection antibody is negative. E antigen, only thing that was present in the case was investigation of choice. Okay, doc, I'm still waiting for your comment. I could not follow up your query. The question mentions yeah, doc, this is a repeat from previous INI-CET only. If you go through the previous discussions, you will find this one where only total antibody is the core antigen is present. I'll give justification for all of these aspects. Doc, the best way for diagnosis of thyroid is evaluation of free T4, free T3 and TSH. That's how we go ahead with diagnosis. It is free T4 and free T3. It's not total T4 and T3 that make a diagnosis, and total T4 and T3 can be normal as well. Okay, chronic hepatitis B, we can absolutely, doc. Ishan, that is what I'm saying. No, TSH and free T4 is what we are supposed to write. You've written FT3 followed by T4. It should be T4 followed by T3. Okay, anyway, let's just solve it. I mean, I can rule out hepatitis B. I cannot say chronic hepatitis B because that serological definition of surface antigen positivity and the IgG class of antibody to the core antigen is not given. So the first option can be ruled out. And then when we look at the inactive carrier state, I'll show you a Harrison reference also. Inactive carrier will be having surface antigen positive. It is only that in an inactive carrier, the hepatitis B DNA values will be substantially reduced. I'll just show you the reference for the Harrison for inactive carrier as well. And this is a snapshot with the page number from Harrison saying inactive carriers are patients with circulating hepatitis B surface antigen. So I know that couple of students sent me this message saying that, I got answer as inactive carrier. Well, this is the definition of inactive carrier. The textbook reference is mentioned here before you. So it cannot be an inactive carrier, and therefore we are left between two only: hepatitis B in the remote past and a window period or a gap period. In the window period, you should be having IgM class of antibody to the core antigen. And in this question, there is no mention of any IgM class of antibody. There's mention of only a total antibody to the core antigen, which basically means it is immunoglobulin G variety. And that immunoglobulin G variety of antibody is the one that would be present in remote past. And we have references for the same as well. I mean, this is anyway a WHO handout. And even before I focus on a WHO handout, why to focus on WHO handout when we have Harrison with us? And in Harrison, you will notice that there are only 4 possibilities where surface antigen is negative. Here, because now the slide is going to be cut out, so the first entry is surface antigen negative, so 4 possibilities ho sakti hain. Either it can be, no doctor, it's not a controversial question because I have highlighted this even earlier, that these तो ऊपर वाला दिस टेबल हैज टोटल ऑफ 8 एंट्रीज, वो सरफेस एंटीजन प्लस वाले चारों परम्यूटेशन कॉम्बिनेशन वो पूछ सका है. सो देयरफॉर इन दिस पर्टिकुलर केस इट इज ऑल नेगेटिव वाला situations. And if you look at the negative situations, it cannot be acute hepatitis B because hepatitis B acute variety needs a IgM class of antibody. It cannot be recovery because recovery will be having immunoglobulin G. The only thing that is fitting up is this one. The only thing that is fitting up is this one where everything is negative and is given two possibilities for this: low level hepatitis B carrier and hepatitis B in remote past. I double checked with everybody. Everybody said, sir, it was not written low level hepatitis B carrier. It was not written low level hepatitis B carrier. Comment in the chat box if it was written low level hepatitis B carrier. Sir, the questions are framed from textbooks only. They cannot create something new out of their mind. So they have to give a possibility because after all they have to give justification for why an answer to a question is there. Obviously there would be some leverage with respect to updated guidelines and stuff like that, but otherwise with respect to the routine data, if there was no low level carrier, inactive carrier, then the only possibility that is left is hepatitis B in the remote past. My suggestion to you guys would be, this is what is discussed in the app, this is discussed right now at the moment as well. You can take a snapshot of it, but just practice these 4 permutation combinations with surface antigens negative. Even in the older INI-CET discussions, I've highlighted upon that. We tend to focus on that easy wala part, including the gap period part, but it is the hepatitis B negative wala, which is the one which would be present. Ishan, even if it is not total given, but that antibody against the only thing that is positive in the patient is antibody against the core antigen. And if you look at antibody total likha ho ya antibody to core antigen likha ho, we take it as immunoglobulin G variety, and I have a reference for the same as well. So if it is chronic inactive, doc, that inactive carrier ka definition I've told you. So the first two options can be ruled out on the basis of baseline data and the reference, and then we have another one where anyway, I mean, this is a slide from WHO that we have to take out, and this also mentions regarding IgG for antibody against the core antigen. He mentions regarding a constant marker with respect to gap period में surface antigen. No Rahul, gap period में surface antigen negative है, तभी तो gap period बोलते हैं ना यार उसको, कि surface antigen भाग जाता है. सुनना, you know, try to listen to that. The gap period has a surface antigen negative, only the positive part. So I think guys, we on the basis of the references that I've shown you, between the remaining options, I mean, before all other options can be ruled out, the correct answer for this one would be option number C. And I'm giving one more opportunity. If the word written was low level hepatitis B carrier, let me know. If it is not, then we can put this. This is absolutely not a controversy according to me. I mean, that infective endocarditis one, yeah, tough one. I agree to that. You know, catheter tip dal raha hai. Two options there are central, two options from peripheral vein, one from a central vein. I understand. I mean, that is not given in Harrison, so that is something which is always, you know, the examiner has picked up a data from a journal per se and has asked question from the same. But as far as this one is concerned, it has to be the textbook data. So डॉक्टर शाह साहब गिवन जस्टिफिकेशन नो, आपको हैरिसन का रेफरेंस दिखा दिया. तो अब हम फैकल्टी की बात नहीं कर रहे ना. इट्स नॉट अबाउट कि फैकल्टी विल गिव एन आंसर बेस्ड ऑन द इनपुट्स दैट आर बीइंग प्रोवाइडेड. सो इट इज़ लाइक आप टेक्स्ट बुक के बेसिस पे उसको सॉल्व कर लो ना. आपके सामने तो है ये जो हैरिसन का टेबल है, उसमें 4 ही तो हैं जिसमें हेपेटाइटिस बी नेगेटिव है. तो आप उसी में से देखो ना कि कौन से वाला जो है दैट वुड बी द बेस्ट वन दैट वुड हेल्प अस इन सॉल्विंग इट. Yeah, Dinesh, can't be immunization because that will have antibody against surface antigen, and the antibody against surface antigen was negative in this case. भाई टेक्स्ट बुक से बाहर से तो कहीं से क्रिएट नहीं करा होगा ना, क्वेश्चन तो यहीं से क्रिएट हुआ होगा. आई मीन ये 8 ही तो परमोटेशन कॉम्बिनेशन है. 4 में सरफेस एंटीजन पॉजिटिव होता है, 4 में सरफेस एंटीजन नेगेटिव होता है, तो वहीं से तो कहीं ना कहीं उसने क्रिएट किया होगा ना. एंड व्हाट आई एम शोइंग यू एट द मोमेंट इज कि जो क्लोजेस्ट रिपोर्ट है, जो आप मुझे बता रहे हो कि सर इस टाइप का रिपोर्ट नेगेटिव था, सब कुछ एक ही चीज़ पॉजिटिव, दैट्स वैलिड ओनली फॉर वन सिचुएशन. ये IgG को ही टोटल लिखता है, दिस IgG को ही ना, दैट इज रिटन एज टोटल वैल्यू. ओके. Moving to the next one, this is a repeat from NEET exam. The question said a child is brought to the emergency room in an unconscious state after severe vomiting and abdominal pain episodes. The heart rate is 100, BP is 100/60, so pretty decent. Workup of the patient shows acidosis with elevated blood sugar and ketones. So he's saying what is the management for this case, and we do not give a start dose anymore for management of these patients. Especially for pediatric diabetic ketoacidosis, it is mentioned that we do not give a start dose in a patient, and it has been replaced by giving a standard insulin drip in a patient. So because it is written start dose, no doc, it would not be B for this particular case. Please go through the NEET PG 2023 discussion as well. The same snapshot is what I've shown there as well. And I would like you to focus on this, that when would you be using subcutaneous insulin if it is a minimal dehydration in a patient. But in our case, he was describing vomiting, and he was mentioning patient is acidotic, so our patient is falling into this category. First, how am I selecting what should be the answer for this question? If he mentioned minimal dehydration in a diagnosed case of diabetic ketoacidosis, patient can take oral fluid, then I'll use subcutaneous insulin, which was one of the options. But considering that in my case it is acidotic, it is vomiting present, so we are taking it to be suffering from moderate to severe dehydration, and that means that the person has to be subjected, first has to be given a fluid correction. The fluid correction obviously needs to be done over 24 to 48 hours, but we need to give fluids to this patient to bring up the blood pressure values, and then subsequently insulin infusion in the patient would be started. So what he has done for the update is only that they have removed the administration of a bolus insulin in a patient. So absolutely doc, that dosages were given 0.05 to 0.1. That dose is present everywhere in each of these options that I've described there before you. But the main point is why answer is not D and why the answer is option number A is because in this particular case he has already mentioned that the patient is having acidosis. He's given features suggestive of moderate to some dehydration in a patient. So what I'm gonna do in this patient is infusion of insulin dose after, look at the word said, after 1 hour of IV fluid admission. That is what I was trying to say here. So IV fluid first and then IV insulin in a patient. Absolutely doctor. The correct answer for this one is option number A on the basis of the input from the table that I mentioned, and this was this was a question repeated from NEET PG last year. Okay. Moving to the next one on the slide, he is mentioned about a 6 COPD patient. ये मुझे बता देना COPD लिखा था ये नहीं लिखा था, फिर pH तो खैर it's gonna be less and PCO2 is elevated, so it's gonna be respiratory acidosis. Bicarb of the patient is 28. तो compensation तो अभी मतलब partial it's a uncompensated scenario slash a partially, मतलब अगर मैं average लेके चलूँ 22 से 26 तो थोड़ा सा elevation है bicarb का, and that is why I can say it's a partial compensation. Fluids after IV insulin, okay, absolutely. Okay, Nick, I think your chat was going a little slower then, and that's why you mentioned the data at the moment. Okay. Okay, PCO2 the patient is 60. That would not change much, doctor, because even in those circumstances, the bicarb of the patient should be much higher. So this would be a partial compensation. बाकी मुझे बता देना थोड़ा सा with inadequate metabolic compensation. Okay, patient is dyspneic, fine. That is a good input. Lokesh has given me a very interesting data here, which is with respect to respiratory acidosis with the inadequate. Okay, so partial की जगह पे it would be inadequate. This is what you're trying to say, right? Inadequate compensation. Fine, got it. Fine, Mohanraj and Lokesh, I think now it's okay. I mean, instead of partial, the word would be a inadequate compensation present. So rest makes sense. Respiratory acidosis, the chap would be having hypoventilation. There's a buildup of carbon dioxide. No, the guy would be having a COPD exacerbation, and that is why he has come up in the hospital. PCO2 60 तो asterixis भी करा सकता है. So it's an incomplete compensation, and that I think would help us in narrowing down the correct answer for this one. Okay, so I think we are sorted for this one. This would be a partially compensated respiratory acidosis. One option had a hyperventilation. Yeah, Ayush, that is what I am trying to ask. Which one had a inadequate metabolic alkalosis in the last of option B? Okay, inadequate metabolic alkalosis. Fine doc, that makes sense. I mean, in a respiratory acidosis, the compensation process is not working. So that makes sense in this particular case. Yeah, doc. I have modified that. No, instead of writing inadequate, I can write incomplete. That's okay. I mean, that would make the same sense. Two option hyper and two. Yeah, doctor, that is very much there. KK. There are two options of hyper and two options of hypo only. So just let me know for point number two. If we have to justify point number two, just let me know whether the wordings are correct. Respiratory acidosis due to hypoventilation makes sense. That's why there is the guy is admitted in your hospital, and then there's an inadequate compensation. The process, the compensatory process should not be working. विशाल, एडिक्वेट एंड इनएडिक्वेट इज सॉल्व। आई थिंक आप पढ़ना इसको, एबीजी में डिस्कस्ड है। पार्शली कॉम्पेंसेटेड होता है, एक तीन होते हैं ना, अनकॉम्पेंसेटेड होता है, एक पार्शली कॉम्पेंसेटेड होता है, एक फुली कॉम्पेंसेटेड होता है। तो एडिक्वेट का मतलब होता है फुली कॉम्पेंसेटेड, मतलब उसमें पीएच नॉर्मल हो जाता है ना। एडिक्वेट में पीएच नॉर्मल हो जाता है ना, 7.35 से 7.45 के बीच में हो जाएगा। Sir, there are two videos on ABG where I mentioned about partial compensation and there are three MCQs. Uncompensated होता है, उसके बाद में partially compensated होता है, fully compensated होता है। तो वो पढ़ना सर, वो मैंने डिस्कस किया हुआ है। तो I think we can go beyond that. Yes, Shahrukh, that makes sense. Respiratory acidosis. Okay. Fine, fine, fine. Only Shahrukh, I'll just make a correction there for that respiratory acidosis occurring due to hyperventilation would not be there, no, because there would be a COPD exacerbation in a patient. So that's gonna be hypoventilation present. Shahrukh, the word only point against what you said is instead of hyper, it has to be a hypoventilation. That would explain the buildup of carbon dioxide in this case. So I think it makes sense for option number B to be the right one for this one, but I'll just refine the options. Instead of saying partial, we'll modify this as incomplete statements there. Due to COPD, he has developed hypoventilation due to fatigue and he developed respiratory alkalosis. No, doc, he has developed a respiratory acidosis. Absolutely not. It's a COPD exacerbation which causes respiratory acidosis is always a COPD exacerbation, doc. Otherwise, he would not be. COPD patients traditionally have respiratory alkalosis, but when they are admitted with us, they develop respiratory acidosis. So I think I'll say that again. भाई COPD में यार लंग में डैमेज है ना, ऑक्सीजन पूरी पहुंच नहीं रही, सो तेज तेज सांस लेगा। मतलब कंपैरिजन में, आपके मेरे कंपैरिजन में, if they climb stairs they'll breathe relatively harder, so on a long term basis their CO2 will be on the lower side of normal. But in the same chap, if there's exacerbation, the carbon dioxide values will begin to build up. Okay, so we are sorted for this one. Let's move to the subsequent one. We are having a patient who's having hyperpigmentation on distal fingers after being hospitalized post adrenalectomy. मुझे आंसर तो मुझे मालूम है, आप मुझे आंसर मत बोलना. Yes, Gauri, there is less in exacerbation, carbon dioxide निकलेगा नहीं ना बार. It would accumulate. That's why the person needs to be put on that NIV ना. COPD exacerbation हम नॉन इन्वेजिव वेंटिलेशन क्यों यूज़ करते हैं? क्योंकि कार्बन डाइऑक्साइड रिटेंशन हो जाती है ना, कार्बन डाइऑक्साइड को तो निकालना होता है जो बुल्लाज में ट्रैप हो रही है. Okay, Mohan, we going too much into physiology. The simple funda is that exacerbation will cause a hypoventilation. Utkarsh says in chronic bronchitis, hypo or hypo. Sir, they would be having hyperventilation, but if there is an exacerbation, then there would be a hypoventilation. If your single best answer, Utkarsh, you are asking me, I'll answer hypoventilation क्योंकि airways block हो जाते हैं पस से. There is a component of purulent bronchuria present in this patient. The smaller airways are occluded, so I'll say hypoventilation in a patient. नेल्सन सिंड्रोम आंसर मत बोलो यार, मुझे ये बताओ, ये डिस्टल फिंगर लिखा था कि पाल्मर क्रीजेस लिखा था? Answer is okay. Please just let me know whether in the options is it palmar creases and sole creases or is it fingers. Yes guys, waiting for inputs. With respect to answer तो नेल्सन सिंड्रोम है, मैं पता है, बस उतना बता देना. Yeah, Lakshman, you're perfectly right. It is Nelson syndrome. Was it distal fingers, like distal finger और the palmar creases वगैरह कुछ mention किया होगा ना? Yes. Okay, distal fingers only. Thank you, Divya Jyoti. Thank you so much. So probably he's talking about the distal finger and he's talking about creases only. So ठीक है, fine. Fine, our answer would not change anyway in this particular case. Nelson syndrome occurs post-adrenalectomy because there is loss of inhibitory control, and that loss of inhibitory control will cause ACTH values to spike, and ACTH has a positive MSH-like action, and that is why the hyperpigmentation of the chap can be explained. The subsequent question is on Addisonian crisis. There is a known case of RA patient who presented to ER with hypotension. Patient is on medication for RA treatment. Please let me know if steroids was mentioned in the MCQ with respect to, or whether it was just written patient is on medication. The problem in this patient are following: the BP of the patient is low, blood sugar of the patient is low, low sodium, elevated potassium, and if I look at the options here, then these three options can be explained by low aldosterone, and hypoglycemia can be explained by low cortisol, and therefore in this particular patient the Addisonian crisis has to be handled on a war footing, and for management of this Addisonian crisis Dexona would be given, dexamethasone would be required. Okay, so not mentioned, will give steroids to this patient with a Mineralo and a glucocorticoid activity that will stabilize the BP as well as the blood sugar of the patient. So life-saving management. Okay, instead of most appropriate, it was life-saving management. The question is on Addisonian crisis, as you can pick up, and the life-saving management in this case would be hydrocortisone. Insulin was among one of the options. Okay, doc, even if I say emergency treatment, whether I say life-saving treatment, it would not make too much of a difference. Okay. Okay, so the dose was also given in the question. I don't think so. They would have given a dose. It is just that you would have mentioned dose from your clinical experience, the 100 milligram hydrocortisone shot. Okay, so we come to a question which has been widely debated as far as CMDT is concerned, and what Harrison is saying, I'll mention that. And then there are a couple of updated guidelines also, recent guidelines also, which are saying a different answer. And this was the image probably on the chest, on the axilla, S-char was present. So as far as CMDT and Harrison are concerned, since the MCQ is mentioning regarding presence of a bilateral rails in a patient, and then is also mentioning regarding a S-char. So the test in this patient which is positive is IgM antibody for oriental tosutosugamusi. So that this would be a presentation of scrub typhus with pneumonia, and this would be a severe manifestation. As far as CMDT and Harrison are concerned, I'll just show you the snapshot also. They have mentioned doxycycline as a universal treatment for this patient. So if the AIMS people are following the standard textbook, then the answer is doxycycline only. It's only the recent guidelines which have come up in 2023. There's a paper that is published. I'll show you the PubMed link of the paper also. This is the PMID. You can just take a snapshot of it, and if you just Google the PMID in this particular patient, yeah, Amit, that is what I'm trying to say, that it depends on the examiner. I'm showing you both the references. In current medical diagnosis and treatment and in Harrison, there is no mention of combination of doxycycline as well as azithromycin. So if the AIMS people are following a standard textbook, the answer would be given as doxycycline only. You can hear very well say that he says azithromycin is shown to be as effective as doxy, but it is more expensive. It doesn't talk about, and मतलब थोड़ा बहुत ही expensive है, ज़्यादा cost में difference नहीं है. But Harvinder, you can mail me at marwahmedicine@gmail, and I'll be glad to assist you. But it doesn't talk about any combination, in spite of saying poor prognostic factors, and he does talk about this, but he doesn't say that we need to make any combination. So all I can say is that if it is going to be a recent guidelines in the question to be followed, then it's okay. I mean, we'll be answering doxycycline with, why answer is D for this question is based only on the recent guidelines. Otherwise, standard CMDT Harrison still goes by management with doxycycline only. So I think the main concept is, I think he did mention about intravenous dosages in this question. I just removed that word intravenous, otherwise we would have got into that oral versus azithromycin. But then he says the recent guidelines mention regarding the combination which is available. Otherwise, standard answer is doxycycline only. So patient had liver disease. Yeah, I think in this particular case, he did mention about LFT, KFT of the patient. Ishan, I agree to that. I mean, this is totally, I would personally think that they would be going by textbook only. So I mentioned both the datas. I mean, the data is like this. Doxycycline is what is given for the textbook. PMID is PubMed Index, doctor. That is one of the biggest resources, right, from which you can find out about any article. This is New England Journal of Medicine, where this has been mentioned. That is combination of doxy and azithromycin is what they have mentioned. Otherwise, LFT was deranged. So, doc, my point is only one. If LFT of the patient is deranged, or if the KFT of the patient is deranged, or there is a severe lung involvement in a patient. So, my point is simple. If it is gonna be a life-threatening illness, why not go out with all the guns blazing? Anurag, let's not fight it. Let's go with the flow. The concept is, if I am fighting a battle against a disease where I'm gonna lose my patient, I'll be happy giving with all my firepower possible, and that is where this marked only. So let's not get into this, doc. I mean, the only concept is, with we go out with all guns blazing wherever there is gonna be I would say threat to life of a person, and otherwise in traditional cases we can go ahead with doxin. Yes, Nilofer, I removed that IV from all the options because that would have made it options longer and would have made us go into that IV word again and again. So I did say that. So let's not argue about it and take it on the chin. Let's look at another one, which is a sitter, where he's talking about a patient who is having bleeding disorder, and she's having her father and sister having the same bleeding issues. So this tells us it cannot be X-linked recessive. And then I'm left between von Willebrand disease and a factor 10 deficiency. Factor 10 deficiency can be having autosomal recessive as well as autosomal dominant inheritance. It is much less common as compared to von Willebrand disease, which has an autosomal dominant presentation. Considering a female patient, okay, if they mention autosomal dominant, then it is even much more easier. If they mentioned autosomal dominant, then it is even much more easier, von Willebrand disease. Okay, so I didn't know that autosomal dominant was described. But yeah, I mean, if we can figure it out now, that is if I mean, a female is having, and then father is also having, and then a sister is also having, so it would be autosomal dominant. So I think this was a sitter and can be solved. The next one was on PMC, that was pseudomembranous colitis, and the patient is taking ampicillin for a URTI, खांसी जुकाम के लिए, और अभी को या वायरल नहीं था, उसको बैक्टीरियल इन्फेक्शन था, URTI, and now person is having watery diarrhea for 3 days. So for pseudomembranous colitis, we have a couple of options. In this case, we'll be using fidaxomicin, and the monoclonal antibody part would only be reserved in those patients where we are having recurrent episodes of PMC. Otherwise, there is no role of monoclonal antibodies to be used in routine cases. So I think that would be a citrin. Okay, thank you. If we did not have it, that is much easier. Okay, fine. The subsequent one was regarding a patient having a high grade fever for past 1 week. Let me know if any lung findings was given in this case. Then there's a neck stiffness and Kernick sign positive, and the CSF analysis shows lymphocytosis. Indian exam lymphocytosis, you have to think in terms of tubercular first, viral then. In viral, then sugar should be normal. Here the sugar values are lower. So I think there were two options with, okay, sort of still I think we can lay rest to the one previous one, because we already had a couple of heavy duty ones to be handled. Okay, so there's no lung finding. Protein was 62, sugar was 40, random blood sugar. Okay, so random blood sugar, that is a good fact. Random blood sugar is 140 and the CSF sugar is 40. So that's gonna be 25%, right? Let me just divide this. Just help me with the mathematics, guys. It's 40 by 140, right? That I need to do. So this would be less than 0.4 anyway. I mean, 140 into 4 would be 560. So if the value of CSF sugar is less than 0.4, that is hypoglycorachia. And considering hypoglycorachia, the ratio should be this, no? Because you mentioned this value, that is why I said if the CSF sugar and the random blood sugar is given, then we have to calculate them the way I did. And if it is less than 2/3, less than 0.4, hypoglycorachia, and considering that there is lymphocytosis, we should go first in favor of tuberculous meningitis. Then there were two viruses that were present. I mean, how am I ruling out the viruses? The CSF sugar would be normal with respect to virus. And how am I ruling out bacterial meningitis is because bacterial meningitis will be having polyneutrophils present. So this would be proteins was elevated. I think Ankit, your data was well received, and thanks for that values. I was looking for that because they should data with respect to it. Okay, so we are sorted for the following question. The correct answer for this one would be option number A, and we can proceed with the subsequent question, which mentioned a 30-year-old HIV positive patient with a neck rigidity and a papilledema, and then he's talking about capsulated organisms being positive for India ink staining, and he says which of the following statements. Rahul, I think I missed a statement of yours. Rahul, for which question are you mentioning your comment? Because I think, and similarly, Nilofer, can you just let me know for which question did you mention for menorrhagia? Rahul, I am just waiting for your next comment to come up so that I can mention this one. Yep. Yeah, Rahul. CSF sugar will be lesser in a patient who's having CSF sugar will definitely be lesser in a patient who is menorrhagia. Okay, menorrhagia was present. Fine, got it. I'll just add this up here, menorrhagia component. So that gives us more credibility to the presentation of von Willebrand disease in a patient. So I think, doctor, that is perfectly fine. For this one, Rahul, Nilofer, I got your point. Rahul, I still did not get what you were trying to say. And can sugar be low enough? Yes, absolutely can be. Yes, Rahul. For this one, right? The sugar value that you're saying, no. So sugar values will be lower, doctor, in a patient in tubercular meningitis. If you pick it up early, there would be a CSF lymphocytosis. See, my thought process in this particular question was that one option was fungal meningitis. Now, let me know if there was anything like a immunocompromised patient for this case, or let me know if there was any option like a fungal meningitis. What I got a feedback was there were two viruses that were given, and for two viruses I mentioned the sugar. Yeah, Rahul, that is what I said. The CSF sugar can be low in tubercular meningitis. Absolutely, yes. But then the remaining things, no, if you're saying pyogenic meningitis में तो यार CSF sugar zero हो जाता ना. अगर आप पायोजेनिक मेनिंजाइटिस से कंपैरिजन मोड में बोल रहे हो तो फिर पायोजेनिक मेनिंजाइटिस में तो CSF शुगर जीरो हो जाता है. आयुष सेज देयर इज नो फंगल मेनिंजाइटिस, तो आई थिंक इवन आई वाज नन ऑफ द अबव ऑप्शन. चलो ओके फाइन, आई ट्राई टू वेरीफाई दिस, बट थोड़ा अनलाइकली है कि नन ऑफ द अबव होगा, बट स्टिल ओके. वायरल ट्यूबरकुलर एंड नन. ओके, समीना सेज ऑप्शंस वर हर्पेस सिम्प्लेक्स, वायरल एंड कॉक्सैकी की जगह पे इट इज नन ऑफ द अबव. Fine, doc. I think in an Indian exam, lymphocytosis should always be thought of as tubercular meningitis, and favoring the diagnosis would be a low CSF sugar because that would be normal in viral etiology. Okay, high opening pressure. Fine. Thanks, guys, for the inputs in this particular case. The high opening pressure term will also be added in the final output. Great. Let's move on to the next one, where we were talking about cryptococcal meningitis in a AIDS positive patient. The problem with option number C was, no, Ishan, that is okay. Ishan, I think the data would be sufficient. The concept is lymphocytosis with normal sugar, lymphocytosis with elevated sugar. Sorry, it's lymphocytosis with low sugar and lymphocytosis with normal sugar. That should do the job. Absolutely, Dr. Venkatesh, that is what I marked it. Okay. India staining in Cryptococcus, we use amphotericin B with 5-flu cytosine. So considering that 5-flu cytosine is not present, he is asking which is a true statement. C does not make sense. And yes, it should have. Ankit, you perfectly right. Initiate treatment with liposomal amphotericin B with 5-flu cytosine. So alone amphotericin B would not make sense. Brain imaging showing changes in 80% of cases. I mean, this is the statement which I would be a little skeptical of answering, that neurological findings are present. If patient comes early, I mean, if stroke does not produce changes, that if a fungal meningitis producing florid changes would be very, very lesser. So that is why I put a plus minus in front of it. And CSF pressure remaining normal. He has himself mentioned papilledema. So if he is himself saying papilledema, then there would be unlikely to say that CSF pressure will remain normal. So I'm ruling out two options in this case. I'm left between B versus D. And you see, there is always a risk of iris. No, if you start antiretroviral therapy in these patients, I mean, anytime there's an opportunistic infection, you have to delay the onset or initiation of antiviral infections. You have to delay the onset of treatment in the patient with respect to antiretroviral therapy. Otherwise, the risk of iris is very much there. So, option number B makes the maximum sense in this particular case. Delay antiretroviral therapy by 2 to 3 weeks. Absolutely, absolutely. Ankit, you are spot on in this particular patient. Doctor, any patient, if he's himself mentioning papilledema in a question, then option number A would be a very difficult one to comment on. No? CSF pressure remaining normal. Any CNS infection will ultimately result in, if not gross elevations, it will result in a mild to moderate elevation of CSF pressure, which will cause symptoms in a patient. Okay. So I think we sorted for this one, the option number B. And we look at next one. 40-year-old patient is presented with grade 2 steatohepatitis, and there's a regular intake of 2 to 3 drinks of alcohol in every day. Initial CSF pressure was high. Doctor, we give both of them simultaneously. Amit, उसमें ना दोनों को एक साथ दे रहे होते हैं. बोथ आर टुगेदर. बाद में फ्लूकोनाजोल देते हैं. बोथ विशाल एंड अमित, आप सुनना डिस्कशन को, उसमें मेंशन है एम्फोबी प्लस फ्लूसाइटोसिन और बाद में फ्लूकोनाजोल देते हैं. तो अगर आपका पॉइंट है ना कि सर हैज़ टू करेक्ट इमेजिंग फाइंडिंग, क्या होता है सर? सोप बबल अपीयरेंस ना, जो रेडियोलॉजिकल फाइंडिंग होता है ना क्रिप्टोकोकस का, सोप बबल अपीयरेंस. आप क्रिप्टोकोकस मेनिंजाइटिस को सुनना एक बारी सीएनएस वाले पार्ट में. सीएनएस इन्फेक्शंस के में दो मेनिंजाइटिस के 2 वीडियोस हैं. सो इन द सेकंड वन इट वुड बी मेंशन्ड, द सोप बबल अपीयरेंस का इमेज भी मेंशन्ड है. Yeah. For all of them, doctor, for all opportunistic infections, we should see when patient will come to me. पहले मैं इलाज करूंगा ना यार उसका acute infections का, ठीक करके फिर antiretroviral therapy देंगे. meningitis वाला मरीज कहाँ से मतलब रोज दवाई खा लेगा? मान लो he is having a raised ICP, is puking all the time, so उसको उस टाइम पे starting him on antiretroviral therapy at that point of time will, I mean, iris का रिस्क तो है ही है. मैं कह रहा हूँ प्रैक्टिकली यार, वो मतलब उल्टी कर रहा है, परेशान है, उसको मतलब कहाँ से खिलाएंगे हम उस टाइम पे antiretroviral therapy? So we'll start later always. ओके, कमिंग टू अ नेक्स्ट केस, जिसमें उसने बोला सवाल में कि दिस अ पेशेंट ऑफ ग्रेड 2 स्टेटियाटोहेपेटाइटिस, और फिर उसने मेंशन किया कि जी इसका रेगुलर इनटेक ऑफ अल्कोहल है. ये मुझे मेंशन कर देना प्लीज़, अल्कोहल पीता था कि नहीं पीता था पेशेंट. बॉडी मास इंडेक्स ऑफ 29. यस, द डिजीज इन दिस पेशेंट वुड बी, अल्कोहल इज गिवन. सर ब्रेन इमेजिंग का परसेंटेज का जरूरी नहीं है ना. पॉइंट है इसकी दैट सोप बबल अपीयरेंस इज वेरी क्लासिकल ना, तो रूटीन में तो नहीं दिखेगा ना. ओके, तो पीता था तो फिर अल्कोहलिक हेपेटाइटिस हो गया. सो दिस पर्टिकुलर चैप इज नॉट हैविंग नैश. आवर पेशेंट इज हैविंग अल्कोहलिक हेपेटाइटिस एंड इज ऑल्सो ओवरवेट. देर आर 2 प्रॉब्लम्स इन दिस पेशेंट. हाँ जी, ठीक है अक्षय, गॉट इट. नाउ ऑप्शन नंबर बी और सी जो होता है, ये दोनों के दोनों जो ऑप्शंस होते हैं, लाइफस्टाइल मॉडिफिकेशन, विटामिन ई, डीऑक्सीकोलिक एसिड एंड पायोग्लिटाजोन, दे आर इंटरवेंशंस फॉर नॉन अल्कोहलिक स्टेटियोटिक हेपेटाइटिस नैश. B and C, they are indications for going in for NASH or management of NASH, though they are not FDA approved drugs management wise, but yeah, lifestyle modification of vitamin E is prescribed to patients of non-alcoholic steatotic hepatitis. So NASH per se, I mean, is where these drugs have been tried or clinical trials of the same are mentioned. बट सिंस अवर पेशेंट इज़ हैविंग अल्कोहलिक हेपेटाइटिस और वजन भी ज़्यादा है, तो उसको मैं रेगुलर एक्सरसाइज के लिए भी बोलूँगा, और रेगुलर एक्सरसाइज के साथ में लाइफस्टाइल मॉडिफिकेशन के लिए कि भाई कम पियो, अल्कोहल डेटरेंट के लिए एडवाइस करेंगे उसको. ओके, सो इट्स नॉट अ रेगुलर इनटेक, बट देन देर इज़ अ मेंशन ऑफ इनटेक ऑफ अल्कोहल. Got it, doc. But still, it would not change the situation because if it is occasional intake or two to three drunks, that's fairly substantial ना भाई. वो पीता ही पटियाला पे गया और उसकी हफ्ते में 3 बार पी रहा है, तो that would, yeah Harry, I get your point. Even if it is not daily, पर यार वो पटियाला पे पी रहा है हफ्ते में 3 बार ही, तो वो तो substantial amount of alcohol intake हो जाएगा ना. It was only statiato. Okay, AST ALT was elevated. No, doctor, we will not use ursodeoxycholic acid. It is lifestyle modification only that is to be used. If he says 2, then lifestyle modification with vitamin E. Okay, this is what I was looking for. Right upper quadrant discomfort in a patient. एंड एट द सेम टाइम पटियाला बैग मालूम ना यार, वो 4 फिंगर्स वाला होता है ना, 80 ml वाला जो होता है, पता नहीं एक पैक शायद 20 ml का होता है, तो 4 करो तो 80 ml का शॉट, ऐसे ही कुछ होता है, आई मीन दिस इज ओके जी, ओके ओके, अभी अभी बात कर रहे हैं अंकित, विजुअल एग्नोसिया इसके बाद ही आ रहा है, बस राइट अपर क्वाड्रेंट डिस्कम्फर्ट एंड AST/ALT वाज एलिवेटेड, फाइन. Let me just note down the value, Ankit, and we good to go on the subsequent one. Fine, जी. चलो. This is the reference from Harrison for non-alcoholic steatotic hepatitis, where he says lifestyle changes and dietary modification is the best way for management, and there is no FDA approved drugs for NASH. Okay, comment on the lung disease present. So because FEV1 of the patient is also lesser, like he mentioned normal value, and then he's mentioned about the case also where FEV1 is also less, FVVC is also lesser, and then the ratio is also substantially less in the patient. Then in those circumstances, this would be an obstructive lung disease, and the answer would be given as bronchiectasis. I mean, whenever we do a pulmonary function testing, our initial objective would be to go ahead with identifying obstructive versus restrictive lung disease. ओके जी, आ गया जी, आपका क्वेश्चन आ गया. अब मुझे पहले तो ये बताना कि इस क्वेश्चन में दो इनपुट्स मुझे मिल रहे हैं. एक इनपुट ये है इनएबिलिटी टू आइडेंटिफाई ऑब्जेक्ट, जैसे फॉर एग्जांपल इफ आई शो, मेरे को बोलने देना, उसके बाद मैं आपसे बात करूंगा. इफ इट इज इनएबिलिटी टू आइडेंटिफाई ऑब्जेक्ट, इट मीन्स दैट पेशेंट को अगर आपने कीज दिखाया तो ही इज नॉट एबल टू सी दैट इट इज अ की, और ही इज नॉट एबल टू टेल यू इट इज अ की. बट व्हेन यू विल शेक दैट की, लाइक इट्स अ bunch of keys, right? You showing a bunch of keys to a patient is not able to pick up the key, and if you shake that keys, then the noise of that keys he is able to understand, but he's not able to, or if you make him touch, then he's able to determine. So it is visual agnosia. The question was having visual agnosia present. That is version number 1. वर्जन नंबर 2 विल बी कि उसको कीज टच करने पे, अगर वो की आंख बंद करके आपने उसको बोला क्लोज योर आइज एंड टच, देन इट्स गोना बी प्राइमरली अ मैनिफेस्टेशन ऑफ steatogonosis. So there can be two different clinical presentations. Steatogonosis is with respect to parietal lobe, जहाँ पे पेशेंट को जो ऑब्जेक्ट है उसको आंख बंद करके वो फील नहीं कर पाएगा. लाइक उसको आपने बोला आंख बंद करो, उसको आपने की दे दिया, उसको बोला फील करो अपने हाथ में, तो इज़ नॉट एबल टू अप्रिशिएट इट. सो जो आप आंसर बोल रहे हो ना सर, विजुअल एग्नोसिया के लिए दैट इज गोना बी आंसर्ड एज टेम्पोरल लोब. Then if this is the data of the question, inability to identify the object, जैसे वो की को आइडेंटिफाई नहीं कर रहा बट कलर टेक्सचर शेप ऑफ द ऑब्जेक्ट बता देता है. हाथ में आपको कीज पकड़ाओगे तो की का टेक्सचर से बता देगा की है, लेकिन वैसे डी को नहीं बता पा रहा है. नो डॉक, इट वुड नॉट बी अ ऑक्सीपिटल लोब, इट वुड बी अ टेम्पोरल लोब. दैट इज विजुअल एग्नोसिया इन अ पेशेंट. आई हैव रेफरेंस फ्रॉम हैरिसन फॉर द सेम कि एसोसिएटिव एग्नोसिया होता है टेम्पोरल लोब का, बट बेसिक कंसेप्ट यही है कि ये क्वेश्चन एस्टेटोगोनोसिस का नहीं है. ओके, दैट आई गेट इट. लैटरल पैराइटल एंड मीडियल पैराइटल लोब, वो ऑप्शन मुझे समझ में आ गया कि फ्रंटल के की जगह पे 2 ऑप्शंस हो गए, बट वो पैराइटल लोब के ऑप्शंस वर आई थिंक अ डिस्ट्रैक्शन, बिकॉज पैराइटल लोब कब आंसर होगा अगर एस्टेटोगोनोसिस है. मैं एक बार ही फिर से इसको हाईलाइट कर रहा हूँ. आपने पेशेंट को चाबी दिखाया और चाबी देखने पे उसे पता नहीं है कि चाबी है कि नहीं है, लेकिन हाथ में पकड़ाया तो बता रहा है कि चाबी है. दैट इज विजुअल एग्नोसिया. ऑन द अदर हैंड, अगर पेशेंट को आपने आंख बंद करके बोला कि चाबी हाथ में दिया और बोला कि मुझे बताओ कि क्या ऑब्जेक्ट है, और वो नहीं बता पा रहा, दैट इट इज अ की, दैट इज एस्टेटोगोनोसिस. सो आई थिंक द क्वेश्चन वाज ऑन विजुअल एग्नोसिया, and agreed Dr. Ishan that 2 options of parietal lobe medial and parietal lobe temporal, that I will just jot down. But then the question was not on steatogonosis. That's the concept. Prosopagnosia, absolutely yes Orion, it's a version. प्रोसोपैग्नोसिया में वो घर वालों को नहीं पहचान पाता ना. सो प्रोसोपैग्नोसिया इज अ वर्जन ऑफ विजुअल एग्नोसिया ओनली. स्लाइट डिफरेंस है दोनों में कि एक में फैमिली मेंबर का हो गया, एक में ऑब्जेक्ट्स का हो गया. दैट्स वन फंडामेंटल डिफरेंस. बट या ही आइडेंटिफाइज द कलर. तो ऑक्सीपिटल लोब तो वैसे ही बाहर हो जाता है ना सर, बिकॉज ऑक्सीपिटल लोब होता तो कॉर्टिकल ब्लाइंडनेस हो जाती है. अगर ऑक्सीपिटल लोब होता तो कॉर्टिकल ब्लाइंडनेस हो जाती है. So he is able to identify the color, that is okay sir, but the way the data is given, मेरे पास किताब का रेफरेंस है आपके सामने, that would be going in favor of visual agnosia. and I think मेरे हिसाब से जो सवाल था वो एस्टेटोगोनोसिस पे नहीं था. अगर एस्टेटोगोनोसिस से हो जाता है तो हाँ, नॉट आइडेंटिफाई फेस तो फिर तो और भी ज़्यादा आपका कन्फ्यूजन हट जाना चाहिए, बिकॉज इफ इट इज़ गोना बी नॉट बी एबल टू आइडेंटिफाई फेस प्रोस्टोपैग्नोसिया, देन इट इज़ अगेन ऑक्सीपिटो पैराइटल लो, it is again occipitotemporal lobe. Fine, guys. I think I have a reference here, and this is what I was able to identify. So one doctor was there. I forgot his name. Okay. Anyway, guys, I'll just show you what is osteogenesis का reference. Osteogenesis would be damage to dorsal column, medial complex, medial lemniscus tract, and involvement of the parietal cortex. So that is where that parietal cortex के options are to be considered. But osteogenesis का मतलब क्या होता है? तो it is inability to identify objects by feel only. लेकिन जो क्वेश्चन था वो osteogenesis पे नहीं था, इस वजह से आंसर parietal lobe नहीं होगा. Yes, Faiz Adam. That's Dr. Faiz. That's what I'm trying to say. We cannot. The question's diagnosis is not osteogenesis, which is why the parietal lobe cannot be the answer. So in this case, I'll put on my. That was a nasty comment, doc. That was a nasty comment actually. But yeah, I mean, it's a difficult one. INI-CET is known for this one. चलो अगले सवाल पे आते हैं, थोड़ा रिलेटिवली आई थिंक आसान रहेगा. यू आर राइट राहुल मित्तल, यू आर राइट. बट अब एज मैं आई कैनॉट एट द मोमेंट, मतलब मैं एम्पथाइज कर सकता हूँ बट आई कैनॉट गो बियॉन्ड दैट एट दिस पॉइंट टू से एनीथिंग अगेंस्ट एन अथॉरिटी. ओके, we talk about this 70-year-old diabetic man. He is having, I think this is the last one that we have for today. Diabetic man presents after a fall. And उसको बुखार था, कफ था, ब्रीदिंग डिफिकल्टी था. मुझे बता देना प्लीज़ रेस्पिरेटरी रेट उसमें क्वेश्चन में दे रखा था या नहीं दे रखा था. Didn't have any option, levofloxacin. Yeah, doc. Even मेरे वाले में levoflox and cef were not. And Faiz, don't worry, we don't even combine the two. आप पहले तो मुझे बस रेस्पिरेटर रेट बता दो या नहीं है, फिर मैं क्वेश्चन को सॉल्व कर लेता हूँ. रेल्स वॉज मैंशनड. ओके जी, रेल्स थे, वो कंसोलिडेशन हो गया, रेल्स हो गया, बट उससे कर्व 65 स्कोर डिटरमाइन नहीं होता है. तो द क्वेश्चन वॉज देयर डॉक्टर मल्लू. आई थिंक I am getting a lot of feed with respect to this question that we had to calculate a curve 65 score. Yeah, doc. Options will obviously be a little off minus. So I'll just solve that aspects for you guys. Considering that the patient is confused and his creatinine is elevated, 2 to ho hi gaya. That means he needs an admission, and 70. That means the score of the patient here is 3. And if the score is 3, he will need an admission. So if it is gonna be a possibility of curve 65 with a score of 3, he needs to be admission. Sir, creatinine value was given even if BUN is not given. At least I got a value of serum creatinine being elevated in this case. Yes, Azhar, that is what I was looking for. Elevated respiratory rate. Data नहीं था curve 65 calculate करने के लिए. Doc, unlikely है. I mean, that is the data that is very much present. Curve score 3 निकलेगा सर. 70 साल का आदमी है, रेस्पिरेटर रेट नहीं दिया हुआ तो उससे क्या फर्क पड़ता है. रेल्स दे रहा है वो, उससे क्या फर्क पड़ता है. वो आपको यू हैव टू फिल्टर आउट द नॉइज मैन. The question will have a lot of noise. Noise is the rails. The noise is gonna be falling in this patient. Noise is gonna be fast breathing in a patient. Doesn't matter. हाँ ठीक है sir. Tachypnea is very much there. I agree to that. There is fast breathing in this patient or tachypnea. That is cough and breathing difficulty. But in spite of that, तो सर जो मैंने अंडरलाइन किया उससे स्कोर 3 हो जाता तो एडमिट करना है. अब बस बात यही है कि अगर साथ में कोमॉर्बिडिटी प्रेजेंट है, जैसे कि इसमें डायबिटीज़ प्रेजेंट है, तो हम यहाँ पे पढ़ लेते हैं कि भाई करना क्या होता है, जो कॉम्बिनेशन ट्रीटमेंट क्या होता है. तो कॉम्बिनेशन ट्रीटमेंट में अगर पेशेंट में प्रीवियस हॉस्पिटलाइजेशन है, एज, फॉल वाज इन द ऑप्शन एंड मल्टीपल चॉइसेस टू बी सिलेक्टेड. ओके, फॉर okay, so there was no antibiotic which has to be given, and there was mentions with respect to, okay, fine. So you have to calculate, and options were treat in OPD, treat in IPD, and IV antibiotics. Okay, yes, so we will be giving 2 antibiotics for this patient. Levofloxacin and ceftriaxone were 2 separate options. Okay, So sir, we will not give levofloxacin to these patients because levofloxacin, okay, respiratory fluoroquinolones, comorbidity is given in this patient. Calculate, that would be amoxicillin and clavulanic acid with macrolide. It would be a combination of these two, or we can be using respiratory fluoroquinolone in a patient. Either of the two combinations can be used in this chap. So since respiratory fluoroquinolone was a single option present, ceftriaxone was a separate option present. For the management of this patient, we have to admit, yeah, yellow sputum is that inconsequential thing, sir. I think the most appropriate data for the management of this patient in the setting of comorbidities, which is that this chap was diabetic and then he had a fall, we have to consider the following options only. Either it's going to be amoxiclav with azithromycin. Amoxi will be given for gram-positive organism and macrolides will be given for atypical organisms. I mean, amoxiclav for typical organism and macrolide for a atypical organism. The combination has to be given in the patient. If that is in the option, cool. If it is not, then it is a respiratory fluoroquinolone which is to be given in this patient. So respiratory fluoroquinolone, no, sir, even if Dr. MK's curve score of 2 will also require admission, it is 0 to 1 only where you will be giving home treatment. If the score is 2, it is IPD. If the score is 3, you have to go for ICU admission because the mortality rate will increase. So I think, in my opinion, based on whatever input that I have, a respiratory fluoroquinolone would be the best option for management with a curve score between 2 to 3 in the presence of comorbidity present. In case there is no comorbidity present in this case, then we just have to remove beta-lactam from the picture. बाकी सब कुछ सेम है, क्योंकि हम निमोनिया में अमॉक्सिक्सिलिन और एजिथ्रोमाइसिन का कॉम्बिनेशन तो देते ही देते हैं. फर्क सिर्फ इतना है कि अगर कोमॉर्बिडिटी आ जाती है तो फिर अमॉक्सी एजिथ्रोमाइसिन में ऐड क्या हो जाता है, बीटा-लैक्टम ऐड हो जाता है. तो अलोन सेफ्ट्रॉक्सन नहीं देते कभी भी. इट इज सेफ्ट्रॉक्सन इज ऑलवेज विद सेफ्ट्रॉक्सन इन अ कोमॉर्बिडिटी इज ऑलवेज अगेन विद एजिथ्रोमाइसिन. So Ankit, that looks like the best possible explanation at this particular point of time. So I'll just run through the questions once again for those who have joined in right at the moment. You can just calculate whatever you have answered. Obviously the final key is with the AIMS people, but then I think you can just quickly go through. That would be Brugada as a presentation for COVE. Then is the second degree heart block. Then is a combination Gauri. Okay. फाइन गौरी, आई जस्ट से दिस अगेन क्विकली. फॉर अगर पेशेंट डायबिटिक नहीं है, अगर कोमॉर्बिडिटी नहीं है, तो 2 एंटीबायोटिक देते हैं. एंटीबायोटिक के देना होता है अमॉक्सिसिलिन और एजिथ्रोमाइसिन. अमॉक्सिसिलिन किसके लिए होता है? टिपिकल ऑर्गेनिज्म के लिए, और एजिथ्रोमाइसिन होता है एटिपिकल ऑर्गेनिज्म के लिए. अगर कोमॉर्बिडिटी होती है तो अमॉक्सी के साथ में हम क्लावुलानिक एसिड ऐड कर देते हैं. एजिथ्रोमाइसिन वैसे ही चलता है. सेफ्ट्रॉक्सन अलोन नहीं देते, या तो देते हैं अमॉक्सीक्लाव विद एजिथ्रोमाइसिन या देते हैं सेफ्ट्रॉक्सन विद एजिथ्रोमाइसिन इन अ पेशेंट, या फिर सिंगल बेस्ट एंटीबायोटिक में लेवोफ्लॉक्सासिन देंगे. Lokesh, आप मेंशन करो. I'll just run through these questions once again. That is Brugada, then was second degree heart block, then was non-stimulation MI with the following treatment. Okay, Lokesh, I'm coming to that question. एक बार run through इसको कर लेना दो मुझे. Then is excess of heparin contributing to the change in the pH. Then is the malignancy part for hospitalized patients. 3 sets of blood culture with a catheter tip described. That's cool for diagnosis. Then is empagliflozin for patients of HFrEF. Then would be hip circumference for metabolic syndrome. Then is that slide of controversy of that that star appearance versus that of restrictive cardiomyopathy. We're going with the restrictive cardiomyopathy. Anticoagulants are given, sir. Statin was yes, Faiz, that was one of the options, but statin is not gonna be the main treatment. No, we need to mainly give enoxaparin to handle the patient because it's a platelet rich clot. Then is rheumatoid arthritis with a symmetrical involvement. You can keep on counting. Then was a question on hyperthyroidism, where hyperthyroidism was mentioned in the question, and the reference of Harrison was mentioned for TSH with T4 to be done. And why answer is not C? Because total T3 is not going to help in evaluation of hyperthyroidism. It's a combination. ECG question had an anxious patient with a slight depression. Okay, so that would be a non-stimulation MI, right? And one option was giving antacid. Yeah, everyone is saying, yeah, doc, it is ACE inhibitor. Sir, आप पढ़ो ना HFrEF, हार्ट फेलियर विद रिड्यूस्ड इजेक्शन फ्रैक्शन में A+B बताया हुआ है. आप अभी जाके कार्डियोवास्कुलर वाला सुनो, HFrEF वाला डिस्कशन, उसमें बताया हुआ है A+B, और A+B में पहले A देते हैं ना. जो कार्डियक रीमॉडलिंग को प्रिवेंट करता है वो A होता है. आप सुन लेना उसमें that the main molecule for heart failure with reduced ejection fraction in chronic CHF is A+B, and A is the first one to be used. Phase elevated is unlikely because okay, so you're saying it is a ST elevation MI. It's unlikely, doc. Presence of ST elevation. Even if it is ST elevation, sir, the main treatment would be for ST elevation. We go in for a no, doc. It will be simpler than this. It would be simpler than this. One query I have answered for Dr. Ankit, and Faiz, mail me at marwahmedicine@gmail.com for that email, for that ECG that you are thinking about. I think if it is a non-STEMI with lateral lead showing a T-wave depression, T-wave inversion with ST depression, it's the standard presentation. अच्छा अंकित, इसका पॉइंट क्या है यार? बीटा ब्लॉकर पल्मोनरी एडिमा में नहीं देते ना. अगर पेशेंट को, उसमें क्वेश्चन में रेल्स मेंशन थे ना, अगर पेशेंट को अभी भी पल्मोनरी एडिमा है, आप बीटा ब्लॉकर दे दोगे तो लंग्स क्लियर कैसे करेगा ना यार. आप पहले पेशेंट को डीकंजेस्ट करो, और डीकंजेस्ट करने के बाद में उसको बीटा ब्लॉकर देंगे ना. अगर उसको आप बीटा ब्लॉकर दे दोगे तो पल्मोनरी एडिमा जो होता है दैट इज नॉट टू बी गिवन अ बीटा ब्लॉकर, अदरवाइज हार्ट उसको क्लियर नहीं कर पाएगा ना. ओके, लोकेश सेज पेशेंट इज कंप्लेनिंग ऑफ गाउट विद 10 days of start of anti-tubercular drugs. Lokesh, here the wordings are important. If patient is having gout, then you have to stop anti-tubercular treatment. If he's not having gout and only uric acid is elevated, then you have to continue with anti-tubercular treatment. I repeat my statement. I think that is correct. If he, Lokesh wrote, patient has complaints of gout within 10 days of start of anti-tubercular drugs. अगर gout हो गया तो stop करना है. Otherwise यार, why do you want to lose your firepower? Uric acid is transiently elevated in all cases of ATT. And we don't need to lose firepower, man. Otherwise, how will we treat tuberculosis? If we don't give pyrazinamide, we will lose our firepower. Even if the uric acid is 8, 9, 10, if it is asymptomatic hyperuricemia, then it does not require a treatment. We will not lose our firepower and we will continue with the treatment. If he writes gout, yes, I need to stop it. But if there is no joint pain, no redness of the joint, asymptomatic hyperglycemia asymptomatic hyperuricemia does not require a treatment. So I think Lokesh, that satisfies you as the answer, because I know your query would be that some people are saying stop and some people are saying continue, but I've tried to explain to you the difference. If it is gout, we need to stop. Yeah, Kushal. If it is gonna be joint pain, yep, I am gonna discontinue because I don't want the patient to suffer. But if it is asymptomatic, तो यार कोई दिक्कत नहीं है ना. फायर पावर क्यों लूज करेंगे हम अपनी? Okay. Final NEET revision. Yeah, doctor, we'll do that, doc. We'll do that. But then at the same time, my suggestion would be कि जो भी आपको पता चला कि जो भी कमज़ोर टॉपिक्स हैं, वो उन कमज़ोर टॉपिक्स को फोकस करो ना अभी. कि जो भी आपको लगता है कि नहीं यार ये मुझे आता नहीं, ये कर्व 65 स्कोर में कन्फ्यूजन हो गया, तो उसको थोड़ा एनालिसिस करो ना स्लोली. चलो जी. सो आई एम डूइंग अ क्विक रन थ्रू. आई थिंक वो बीच में हमारा ऑप्शन छूट गए थे. सल्फासालाजीन वुड बी यूजफुल इफ इट इज़ माइल्ड अल्सरेटिव कोलाइटिस. Ashish, we can add statins. I don't discontinue. I would not discourage that. But see, primary objective of treating a non-ST elevation MI would be to use anti-clotting drugs initially. Okay, Saurabh, hypertension where blood pressure is elevated, lifestyle modification plus amlodipine. इसमें यार age भी दिया था, I think so. So I think Saurabh, the question would be with usage of drug treatment also. Amlodipine alone तो यार हम नहीं करेंगे ना. लाइफस्टाइल मॉडिफिकेशन अलोन नहीं होगा, दवाई उसको देनी होगी. या 55-year-old मेल ना, तो दवाई देनी पड़ेगी उसको. आई थिंक द फार्माकोलॉजिस्ट हैज़ टेकन केयर ऑफ दैट. So fine guys, I think I have we will put up a modified version of this in the app and you can just go through it subsequently. And I really appreciate that you guys have come and discussed these options with me. It was really nice interacting with all the young guns like you. And I think we have taken care of about 38. I've taken care of about 37, 38 MCQs. I just lost count in between because in between I started answering a couple of queries. So thank you so much, guys. Happy Diwali. I know you guys would be studying hard at that point of time as well, and it causes a despair of gloom sometimes that everybody else is enjoying. But I think that the final outputs are always gonna be I would say much rosier and much more comfortable than what the things are at the moment. So hats off to your dedication. That after an exam, honestly, if I was you, I would not come for any discussion. I'll say कि मुझे छोड़ दो, and I just can't tolerate this once again. But you guys have come up, so I really appreciate that. And okay, Rahul. ओके वी डू अ क्विक रन थ्रू ठीक है फटाफट कर लेते हैं ठीक है एक बार देख लो तो ब्रुकाडा में तो कोई दिक्कत नहीं है देन हार्ट ब्लॉक देन इज एस्प्रिन क्लोपिडोग्रल एंड लो मॉलिकुलर वेट हेपरिन और एक में होगा एस्प्रिन क्लोपिडोग्रल एंड स्टार्टिन यहाँ पे मैंने कंसेप्ट ये दिया यार एमआई का मरीज है तो पहले यार उसको हेपरिन देना ज़्यादा जरूरी है एज कम्पेयर टू एथेरोस्क्लेरोटिक प्लाक में तो टीयर हो गया ना सो आई मीन दैट वुड बी अ लेस एडवांटेजेस थिंग इसका थोड़ा मॉडिफाई करना ऑप्शंस बट इट मेक्स सेंस टू यूज हेपरिन विच इज कॉजिंग डाइल्यूशनल इश्यूज एंड देन इज द वन ऑन malignancy causing symptomatic hypercalcemia. The 3 sets of blood culture with a catheter tip would make sense. Central line जो cut catheter tip भी culture के लिए भेज दिया because that could have contributed to infective endocarditis. Then is empagliflozin. Then is hip circumference for metabolic syndrome. I hope आप count कर रहे होगे. Then is restrictive cardiomyopathy. Then is rheumatoid arthritis. TSH for initial determination of hyperthyroidism in a patient. Then is sulfasalazine. This one would be remote past. I've given Harrison reference for the same. Then is this updated guidelines of diabetic ketoacidosis. It's more of pediatrics actually. Harrison में तो वो अभी भी बोलस डोज बोल रहा है एडल्ट के कीटोएसिडोसिस में कोई चेंज नहीं है सर इट इज़ ओनली दैट पीडियाट्रिक वाले में उसने चेंज करा हुआ है तो नीट पीजी में पिछली बार पूछा था मैलिग्नेंसी वाला क्राइसिस अनुराग क्योंकि यार देख लंग कैंसर वाले मरीज का वेट लॉस होगा यार जो लंग कैंसर का मरीज है उससे खांसी होगी कैकेक्सिया हो जाएगा पैराथोराइड एडिनोमा तो बहुत स्लोली ग्रो करता है तो वो सिम्टम्स उसके आने में बहुत ज़्यादा टाइम लगेगा कैल्शियम धीरे धीरे बढ़ेगा और फिर उसको वो बोन पेन और मोनिंग ग्रोनिंग वाली सिचुएशन आ जाएगी सो इट टेक्स आई मीन ईयर्स फॉर दैट बट लंग कैंसर हैज़ अ मच मोर फास्टर प्रोग्रेशन एंड यू कैन टेक दैट एग्जाम्पल ऑफ यार अपना आई मीन even lung tumors which are benign will be having issues so I mean lung cancers are a nasty lot in fact so बीच में फिर इंटरप्शन हो गया था बट आप आई होप काउंट कर रहे होगे दैट इज इंसुलिन इन्फ्यूजन देन इज रेस्पिरेटरी एसिडोसिस विद द इनएडिक्वेट कॉम्पेंसेशन अकरिंग सर गाबापेंटिन यूज होता है देन इज Nelson syndrome that's gonna be again a presentation because of post adrenalectomy hydrocortisone shots इसका -1 मार्क ही लगा लेना जो भी आप सोच रहे हो उसका उल्टा आई एम नॉट श्योर अबाउट कि वट एवर दे आर फॉलोइंग आई हैव मेंशन बोथ द रेफरेंसेस टेक्स्ट बुक के हिसाब से होना चाहिए देन वॉन विलिब्रांड डिजीज then fidaxomicin, tubercular meningitis. I gave justification for low sugar there. Then was iris concept for meningitis. Option A for because it is alcoholic hepatitis and not was NASH. Bronchiectasis for spirometric data. Divya, the answer would be excess of heparin which will cause a dilutional effect and that will cause the values of PO2 and PCO2 to fall and heparin will also cause the pH of the patient to increase. It is excess heparin as an isolated answer for that changes in the pH and the fall of PO2 and the fall of PCO2 that is seen. Okay, this is visual agnosia. It is not stereognosis as I explained. And then is levofloxacin in case the curve score of the patient is elevated and at the same time that is 3 there is a hospitalization that is required so I think we are sorted for today qualifying score तो यार हर बार vary करता है cut off will vary every time so we can't it's very difficult to predict that and उस पर time लगाने की ज़रूरत नहीं है मेरे हिसाब से तो आई थिंक इफ आई एम एट योर पोजीशन व्हाट आई वुड रिकमेंड इज that one should try to evaluate the weaker subjects, weaker subtopics, and then try and solve them. Yes, Anurag, that's what happens. So I think we are good to finish this discussion for today. Thank you so much for joining. Rahul, they were difficult ones actually. It was like a Sherlock Holmes की story होती है ना, मतलब when I was talking to students तो मुझे लगा पहले जैसे उसने एक वन स्टूडेंट ने ऑप्शन बताया कि सर ये आया था, तो अच्छा ठीक है फाइन, देन द अदर गाइस सेइंग अ डिफरेंट थिंग, तो अच्छा ये नहीं हो सकता, द थर्ड पर्सन सेज कि अच्छा नहीं सर ये हो सकता है, तो इट्स लाइक अ शर्लॉक होम्स का वो डिस्कवरी वाला मोड कि भाई अच्छा दिस कुड बी अ पॉसिबिलिटी दैट वी आर ट्राइंग टू इवेलुएट। सर एमसीक्यूज फास्ट करो, हम टाइमर लगाते हैं मोबाइल लैब जब भी आप करते हो ना, तो आई मीन यू वन इज ऑलवेज फोकसिंग ऑन दैट बार विच इज गोइंग इन द रिवर्स डायरेक्शन, so you need to respect that bar and try to solve questions on a faster pace. So NEET is I mean this is one जिसे कहते हैं ना wake up call, and this is gonna tell you that हाँ यार ये मैं कर सकता हूँ और ये मैं नहीं कर सकता हूँ. So मेरे हिसाब से तो this is like a very good stimulus that we should take in a very positive sense. At least my approach is always like this, even when the going gets tough. तो यार मैं पॉजिटिव सेंस में देखता हूँ, मतलब 1000 लोग नेगेटिव बातें कर लेंगे आपके बारे में, आप जो भी काम कर रहे हो उसके लिए ना, हर फील्ड में होता है, बट अल्टीमेटली आपको हर चीज़ में पॉजिटिव देखना होता है, एंड यू जस्ट कीप ऑन डूइंग योर जॉब ऑन अ रेगुलर बेसिस एंड थिंग्स देन ग्रेजुअली स्टार्ट इम्प्रूविंग इट. सो माई blessings for all of you. Thank you so much, and I really appreciate that you have stayed this long. My email ID is marwamedicine@gmail.com. In case you have any much more queries, I'll be glad to assist you. I mean, just drop me a message and I'll try to revert back to you in the shortest possible time frame. God bless you.